you very much, Adrian, again for introducing me and also for inviting me to take part in this great program. So I've been tasked with talking to you about how to actually approach posterior uveitis, and I always like to sort of start off with just sort of saying what we're going to do. We're going to revise really what uveitis is, and then look at a general sort of management approach, which myself and Rupesh are going to really sort of flesh out over the coming day. So essentially, I always like to start off with a case. This is a 7-year-old boy that I was involved in quite a few years ago. He was one of 4 brothers, and they were all playing cowboys and Indians. And they were playing cowboys and Indians with real arrows. One of his brothers shot the arrow, missed the target, and actually hit the young boy in his eye. Okay, so this is his right eye after the injury, and this is after 2 operations to try and put it back together. And I think some of you will already know what's going to happen here. 6 weeks later, he presents with bilateral sudden-onset ocular pain, severe photophobia, bilateral ocular injection, and blurred vision in his remaining eye. This is the examination of his left eye. The right eye you've already seen, quite inflamed, disorganised anatomy. In the left eye here, though, you can see that he's actually got a granulomatous panuveitis. So you can actually see the granulomas here, slightly hazy view due to the degree of the vitritis. So all of you will know what the diagnosis is. Sympathetic, absolutely. This is the angiogram. Again, you can see here the areas of leakage from the areas of inflammation. And he had very aggressive treatment, and I'm going to talk to you about that a little bit later in a second talk. But the nice thing is that with ongoing systemic immunosuppression, he's actually done very well. So what is uveitis? Now, this is a concept that I found really difficult to sort of get my head around as a medical student. As we know with arthritis, itis is inflammation, so arthritis, inflammation of the joint. Uveitis is obviously inflammation of the uvea, but it's only as a resident that I really understood what actually the uvea is. And just as a revision, okay, it's just inside the eye here, it's the vascular coating the inside of the eyeball. And that means that uveitis is all forms of intraocular inflammation. Inflammation inside the eyeball. And it encompasses all of these, which are anatomical definitions of where the site of inflammation actually is. Okay. But I also know that you've heard of scleritis, episcleritis, orbital inflammation. Okay. These are all also inflammatory ocular diseases, but they are not inside the eyeball. Okay. And so uveitis, intraocular inflammation. Scleritis and episcleritis, inflammation of the eyeball wall. Okay. Orbital inflammation, which includes myositis, dacryoadenitis, and orbital inflammation. That's outside the eyeball, but inside the orbital cavity. Okay. And the reason why I rabbit on about this is because the causes of the inflammation depends a lot on the type of, or where the actual inflammation is. Okay, so this is just a basic schema that we always sort of think about when you see ocular inflammatory disease. Is it infectious or non-infectious? And then you start breaking it down into the different syndromes. Now, this is something that is the reason why I want you to try and sort of split out the difference between scleritis or inflammation of the eyeball wall versus uveitis, inflammation inside the eye. These are causes of non-infectious uveitis or inflammation, and you can see here that the systemic manifestations or associations of scleritis are quite different to the systemic associations of uveitis. Quite different, and that's the reason why you need to have very clear in your mind what you're dealing with, because then you can actually split out what the underlying diseases may be. They depend on where the inflammation is. Okay, so why should we care about uveitis? All right, after all, in our general practice, it accounts for less than 1% of all ophthalmic presentations, but it punches above its weight with regards to the impact on blindness. Okay, so the top 5 causes of blindness in America. Okay, similar in Australia, and probably right up there in Asia as well. And it certainly accounts for about 30% of all cases of blindness in my institution. All right, and the key here is that unlike age-related macular degeneration and glaucoma, which blinds you in your 60s or later when you've already paid your taxes, this actually affects the young. Okay, so young people like yourselves who are still trying to feed their families and they're still paying their taxes. So very high economic burden with regards to uveitis. So that's why it's important. Okay, so I talked to you about the anatomical classifications of uveitis and the ocular signs. I'm just going to go through them very quickly. Anterior uveitis, obviously inflammation is focused at the front segment of the eye where the iris is, hence the term iritis. Intermediate uveitis, it's really focused in the vitreous, which is in the middle of the eyeball there. And this is just a picture of vitritis. And this is pars planitis, which is a form of intermediate uveitis, and it's characterised by the snowbanks and snowballs. Okay, so that's a subset of intermediate uveitis. Posterior uveitis, the rarest form of uveitis, but it's actually the most visually disabling because it involves the retina. Okay, the part of the eye, as we all know, that doesn't recover well when it's injured. Okay, and it encompasses retinitis, obviously, and choroiditis. Panuveitis is obviously when the inflammation is focused in all parts of the eye, anterior, vitritis, and retinitis choroiditis. All three areas are affected equally. And classic examples are infectious, but also Behçet's disease and sarcoidosis. Okay, so the challenges in managing posterior uveitis is firstly determining what you're dealing with, where is the inflammation, how has it actually presented, and do you need to do anything with regards to investigating further, and then when to start treatment. Okay? And these are the things that I'm going to try and sort of go through over the course of the day. So, as you can see here, there is a huge list of causes of posterior panuveitis. And using that initial schema that I showed you, you've got, you've got a whole lot of infectious ones and a whole lot of non-infectious ones. And I'm just going to try and give you a framework of how we're going to do this. So the key question always in the management of an acute manifestation of posterior or panuveitis, the first question you should be asking yourself is this infection? Okay. The reason being is that the treatment of infection is obviously very different to the treatment of non-infectious causes. So the treatment of non-infectious causes obviously is immunosuppression. Okay? Reduce the inflammation with steroids and other systemic immunosuppressants. And you can imagine that that's actually going to make things a whole lot worse if you're actually dealing with an acute infection. So this is the number one question you should always be asking yourself. So how do you tell? Okay? And the most important way of finding this out is a really good, thorough history and examination. It's not a special test, it's nothing else but actually taking the time and actually working out how your patient's presented and doing a thorough examination. So take it to a good history, look at the pattern of the uveitis. Is it unilateral? Is it bilateral? Is it acute onset or are the symptoms slowly progressive? And then look at the patient, okay? Often, we all forget that the eyes are part of the whole body, okay? And often the patient actually has systemic manifestations of their eye disease that you haven't asked them about. And this is just a classic example of the gentleman who came in with hypopian uveitis. And you can see here, he's got that classic sort of frozen spine. He's got ankylosing spondylitis. Okay, and if you actually just don't step away from the slit lamp and have a look, you'll miss these signs. Okay. With investigations, be guided by the presentation. Don't just order a whole lot of investigations without really knowing what's going on. Because basically, as per Bayes' theorem, as you can see here, it's not worth doing them if you don't think that they're going to be positive. Okay? Alright, so simply, there's no point doing the test if the pre-test probability of the disease you're testing for is less than 50%. Just a waste of money. Having said that though, in Australia we're looking at a syphilis epidemic, so we do syphilis in everybody. Okay, so if I just stood up here and just gave you a didactic lecture, I think you will fall asleep. So I thought that the best way to actually go through some of these principles is to actually go through a few case examples of some systemic diseases and some ocular syndromes. Okay. So this is a 40-year-old gentleman who was referred in by a retinal colleague who actually said that he had vasculitis in the central retinal artery occlusion. The fellow actually presented with floaters and decreased vision. And the specialist who sent him in saw all of this sort of vasculitis going all the way to the disc and made that diagnosis. But what he failed to do was actually look a little bit more in the periphery and he had a great big fungating lesion of toxoplasmosis just there. And so all I can say is that if your patient presents with what appears to be anterior uveitis and you just just do a posterior pole examination. It's not enough. You need to dilate your patient's pupil, and you've got to exclude anterior uveitis by doing this. Okay, you cannot call a patient acute anterior uveitis without dilating that pupil and having a look at the posterior pole. If you've got a poor view on day one, okay, dilate them up, put them on cyclopedics, bring them back a day or two later, and just have a look at that posterior pole. Okay, posterior cement. I cannot emphasise that enough. Okay, just a few words on toxoplasmosis, and I know Rupesh is going to talk about toxo a little bit more. It is the commonest cause of posterior uveitis worldwide. Okay, it's most commonly a reactivation, and the patients present with floaters like that fellow did, and decreased vision. Okay, they may have quite an aggressive anterior uveitis, which might be hypertensive, and they do have, like that picture, a classic punched out chorioretinal lesion with an area of active chorioretinitis adjacent to it. But primary infections in adults can occur, and so as a result, the classic punched out pigmented lesions will be absent in these cases. As you can see here, this is toxo. 2 months later, you can see he's now got that classic punched out lesion with that area of pigmentation on the side. So primary infections and primary lesions do occur. The diagnosis is generally clinical. Okay, if you saw this, you can see the punched out lesion, area of reactivation. Okay, I know this is toxo. But sometimes, like in this case, it's not always that clear. Okay, that is when you can actually do some investigations. Okay, a toxoserology is only helpful if it's negative. Okay, because about 90% of the population will have already been exposed. So a positive IgM or IgG of toxo is not that useful. Usually it's just an IgG in ocular toxo, but a negative one makes you think, okay, this might not be toxo, I might need to be thinking about other things. Okay, that's when a PCR might be useful. Okay, an AC tap or a vitreal tap. The sensitivity isn't high, okay, and it drops even further if your patient has already been started on toxo treatment. So if you're not sure at presentation, do the tap early, and the reason I would do that is to exclude herpetic retinitis, which is the main differential in this situation. Okay, this is the next case. This is a young 18-year-old boy who came in with unilateral acute anterior uveitis, which was not responding to topical treatment. You can see here that he's got lots of granulomatous chorotic precipitates, and when he saw me, he had a 2-week history of ongoing photophobia, discomfort, ocular injection in that left eye, associated with some reduction in vision, so some floaters and reduced vision. Now, oops, sorry. Okay, now, this is his dilated examination. All right, you can see here, it's a poor view because he's got quite a lot of vitritis. Now, if you stay looking at his eye on the slit lamp, this is all you're going to see, all right? Just fuzz, okay, because of the degree of vitritis. But if you actually put your indirect ophthalmoscope on, okay, this is what you're going to see, okay? You can see here, classic area of retinitis, okay? This is acute retinal necrosis, all right? So, my little pearl to you is, if there is significant vitritis, okay, you must use your indirect ophthalmoscope, okay? Because if you sit on the slit lamp, it is not enough. You're not going to get enough wattage to actually get out through that vitritis and also get out to the periphery to find these lesions, okay? Because often in acute retinal necrosis, it starts off very peripheral, you're not going to get there on the slit lamp, okay? So your indirect ophthalmoscope is your friend in these situations. A couple of points of I'm just going to go through very quickly. The diagnosis is clinical on history and the examination features. If you're unsure, you can do a tap. And the nice thing is that even though there's a very high sensitivity on vitreous samples, it's also quite high in aqueous samples as well. This is the next case I'm just going to go through. A young 25-year-old female who came in with a 2-week history of persistent bilateral anterior uveitis. Treated topically, didn't really respond, and then came in with a 2-day history of floaters and blurred vision. Okay, and you've done the right thing, you've dilated it up, and you can see these focal areas of retinitis. Now, if you left it at that, you're probably sitting there going, it could be a whole lot of things. But if you actually took the time to ask a bit more questions, she actually had episodic viral ulcers for the past 2 months. Okay, and this is her mouth, or it's not her mouth, but it's representative of it. Huge crops of them. Okay, one episode of genital ulcers also in the previous 2 months. So already you should already know the diagnosis that she's got the chest disease. Okay, again, it's classic acute uveitis. It's a classic cause of the hypopian uveitis with acute onset. Okay, and the posterior segment involvement can be varied. Occlusive retinal vasculitis is what we're worried about most. Retinal infiltrates, like she actually presented with. Okay, and all the other complications. Okay, now up to 70% of those with Behçet's have ocular involvement. Okay, and 20% have ocular involvement as the first manifestation, and that might actually be because there's systemic symptoms like this young girl. Okay. Because they come and go, they never actually went to their physician to actually talk about them. Now, what I want to highlight here is the diagnosis is based on clinical criteria. And there are about 17 different ones, but there's recently been a consensus statement that assigns 2 points to ocular manifestations, genital ulcers, oral ulcers. These are the top 3 things that you've got to ask for in these patients. Because already, if you've got 2 of these, you've got Behçet's disease. And it's not just actus ulcers, we're talking about crops of ulcers, and the patients will actually volunteer that they are incredibly painful. Alright, so I'm sure all of you are feeling a little bit bored by now, so I'm just going to actually change the format for the next slide, for the next case. I've got a 35-year-old female, 2-month history of bilateral red eyes, photophobia, increasing floaters, and bilateral blurred vision over the past few weeks. This is what you see. She's got slightly raised pressure in the right eye. Okay, quite a lot of AC cells, so that's at least 2+. You can see here quite a lot of posterior synetes. Okay, so what are you going to do now? Are you going to ask her more questions? Anyone put your hands up? Yeah? Ask a few more questions?
Yes.
Okay. What would you like to ask? Just have a think about it. Who wants to have a look at the eye a little bit more? I know what I'm looking for. Are you going to order some blood tests? Anyone? Not yet. Good. Okay. Well, who's going to start on topical steroids?
Blindly.
Sorry?
Blindly.
Okay. All right. So the answer is ask her a few more questions, as you said over there, gentlemen. And she actually has a history of a recent diagnosis of asthma. Okay. Over the past 6 months, her primary care physician said, "Oh, you've got some wheeze. Okay, a bit of shortness of breath on exertion. Here, take some Ventolin." Okay. She also, though, had some symptoms of malaise, loss of weight, and an intermittent rash around her ankles. And she actually said, "Yeah, the rash is there for about a week. Big lumps on my shins, and then they go away after a week. So I never really bothered seeing anyone about it." And fortunately, she actually had one when I saw her, and it wasn't a rash. She had these lumps. Okay. So anyone know what this is? Erythema nodosa. Yeah. Okay. So if we look at the eye a little bit more, you can see here with the IFA, granulomas on her conch. Okay. Typical millet seed appearance. It's only I'd never seen a millet seed until I went to America, but these are millet seed appearance. And if you did the dilated examination, which I was telling you you've got to do, okay, you'll see classic periphlebitis, and what you don't want to see is this, okay? So you've got a granuloma on the optic disc, all right? So these are all the reasons why you've got to dilate your patients. All right, so does someone want to shout out the diagnosis now? Sarcoidosis? Yes. Okay. So this is a case where I haven't done any investigations. Okay? I've just spoken to her and I've done a thorough examination. Okay? The answer is often in front of you. Okay? You just need to take the time and actually go through all the systemic manifestations or all the systemic complaints your patient may have in addition to their eye disease. Okay? And she actually had quite pan-uveitis. She's got anterior, intermediate, posterior uveitis. Granulomas, you should already be thinking sarcoid TB. All right? So these are the things you've got to be thinking of, and that's what you've got to direct your systemic questioning about. I'm going to look for symptoms of sarcoidosis. I'm going to look for TB, loss of weight, high fevers, all of these sort of things, productive cough, blood, all of these sort of things. You've got to ask the questions, because that's how you're going to make your diagnosis. Okay, so a bit about sarcoidosis. idiopathic chronic systemic granulomatous inflammatory disease affects all organs, okay, including the eyes. Okay. The typical sarcoidosis patient is 20 to 40 years of age, females more than males, okay, and more common in African Americans than Caucasians, okay, and up to 80% may have an ocular involvement. Okay. The ocular involvement is granulomatous uveitis predominantly when it's uveitis, okay, and you just highlight that up to 30% of those will get posterior segment disease, okay, so sight-threatening disease, but the most common manifestation is actually the dry eye from the dacryoadenoitis. Okay, so these are all the investigations you could order if you wanted to. Okay, and essentially I normally just start with the ACE and the chest X-ray, and also quantiferin gold as well, just to exclude that TB possibility. These other investigations are to actually solidify the diagnosis, and I'll just go through these investigations in a moment. So firstly, angiotensin converting enzyme, okay, it's secreted by macrophages in those sarcoid granulomas, which is why it's elevated in about 80% of patients with sarcoidosis. However, you can see here the sensitivity and specificity, it's so-so. So it may not be positive, particularly in isolated sarcoidosis. So patients who just got sarcoidosis in their eye, the load is not high enough to cause a raised ACE. The other thing also that we're seeing in Australia is a lot of our patients are on ACE inhibitors for their hypertension, and so that may also give you a false negative. And the other thing also, the level is age dependent, so if you actually do this in children, so under the age of 18, it may actually be normally high, so it actually may not be relevant if you're actually ordering this in the young child. Okay, so the other thing also is it's not specific, okay? ACE is not specific. You can see here a whole host of diseases that cause a raised ACE, okay? And up here is TB, which is the one thing you've got to be very careful about. So again, it's not specific. So it helps with circumstantial sort of evidence, but it doesn't give you the slam dunk diagnosis. Okay? The chest X-ray is very useful in this situation. What you're looking for is hilar lymphadenopathy and interstitial lung changes here. Okay? Again, it's not very sensitive. You can see here in patients with definite sarcoidosis, only 68% had a normal chest X-ray. But you do get higher sensitivity with the CT chest. However, there is that radiation exposure with the CT chest. So just be careful in young patients particularly that you've got to have a good reason to do that CT. Alright, so should you do a biopsy in all these patients? After all, without the biopsy, okay, we're all talking only presumed or probable sarcoidosis. So the biopsy is very, very useful. There is a consensus agreement on the diagnosis of sarcoidosis, and we do split it up again into 4 categories: definite, presumed, probable, and possible. And this is just the schema here. Definite, obviously, you've got a positive biopsy. Presumed is when you've got bilateral hilar adenopathy and the compatible uveitis, down to possible where you know the only thing you're finding is maybe a couple of intraocular signs, and that's pretty much it. Okay. So, doing a biopsy, if you see those conjuganulomas like that young lady did, take a biopsy, okay? It's a hell of a lot easier than doing a transbronchial biopsy or mediastinoscopy, okay? It's such an easy thing that you can do in the outpatients, okay? Now, a blind biopsy has been described to actually give you a positive result in up to 70%, but if you actually see these granulomas, I would say you're much more likely to get it. So if you see granulomas, just take a biopsy, nice and easy, quick recovery. Bronchoscopy is a lot more invasive, okay, basically the reason we do it is if we're a little bit concerned, we're not sure we've got the diagnosis right, it's positive in up to 95%. Okay, the treatment depends on the patient in front of you, and I'm going to talk to you about the treatment of non-infectious uveitis a little bit later. And the treatment options, as I tell everybody in uveitis, is drop shots or pills. Okay, so this is the next case, a young 23-year-old Pakistani gentleman, a student who was studying in Melbourne. He came in with floaters, okay? Vision's still quite good, but you can see the cause of the floaters here. He's got gross neovascularization of the disc, and he actually also had a little bit of vitreous cell. Okay, all investigations I like to add were all negative. I was looking for sarcoid, Behçet's, and TB particularly, quantiferon Man2 negative. Okay. Now, he was given some oral preg, bilateral pan-retinal photocoagulation and some systemic immunosuppression, and the eye of faith, you can see that the neovascularisation of the disc has regressed. At that point, you thought he was cured, and he stopped his meds, and he didn't think there was a problem. Okay, but I said, you've got a problem, they've all come back. Okay, you didn't believe me, but then a week later, he's come in with this vitreal hemorrhage, and I felt like saying, haha, I told you so. But basically, at that stage, he returned to Pakistan a week later, at which point I thought, excellent, he's not my problem anymore. But he does illustrate a very difficult condition in uveitis, and that's retinal vasculitis. Now, the problem is that there's no definite agreement as to what comprises retinal vasculitis. And basically, is it just the sheathing that you see in sarcoidosis, or are we really talking about the vascular occlusion, or are we talking about the neovascularisation? But basically, this is just a schema. You're going to get a handout of all these. It's, again, very useful to divide it into infectious and non-infectious, and again, to be able to split between these, it's all on the history and the examination. If we look at the epidemiology of retinal vasculitis, I'd just like to highlight to you that there is a significant proportion that are infectious in nature due to herpetic uveitis, but also tuberculosis, which is something that's a real issue in Southeast Asia. It's a really difficult thing. I've always found it difficult to grapple with, and Rupesh's going to talk to you a bit later about that this morning. If you look at some Asian studies, again, higher proportion of infectious cases associated with TB, and in here there's also the EELS variant, which is what my young fellow had. Okay, so I'm just going to finish off with a last case here, and it just illustrates what happens when the diagnosis isn't clear-cut, okay? The acute undifferentiated presentation, which is a difficult one that we always have to trace. Okay, so we've got a 58-year-old Sri Lankan taxi driver. He came in initially with a 3-day history of fevers, dysuria and lethargy. And then the reason he came in is he had a 1-day history of blurred vision in that right eye. Okay. Injection, photophobia. He came into the emergency department and was presumed to have a urinary tract infection. Urine and blood cultures were taken, initially negative. He had 2 doses of stacked IV ceftriaxone and was referred in to basically get his right eye sorted out. Okay, 24 hours later, he said he was well. He was afebrile at the time. Vision note in the right eye, right down. Okay, and 3+ cells, and if you can see here, he's got a hypopium here. Again, 2+ vitreal cells and haze. No noted focal lesions that could be seen, but with a vision of count fingers, you can imagine how good that view was. Given his history of previous fevers 3 days earlier, it was presumed metastatic endophthalmitis, so we did a tap and inject, okay, and it showed leukocytes, no organisms, culture negative after 24 hours, initial blood cultures and urine still negative, and on further history, we find out his father had TB 8 years prior, and he also had intermittent urethral ulceration, so he had intermittent ulcers. Okay, he had no oral ulcers, no arthritis. So here we've got either, is this infectious or is this not infectious? And that's always that key question that we're trying to think. Okay, the differentials at this sort of point in time is metastatic endophthalmitis given the sepsis, or Behçet's disease or TB. Okay, so all of these are still all in the mix. Okay, at that stage I was saying, look, given the history, I still think this is infectious. I think he needs to stay in, okay, and wait for those cultures to come back. Okay, and that was a question I was being asked. Are you sure it's not Behçet's disease? He's not getting better. He's got that hypopium, despite that ceftriaxone a couple of days earlier. I'm sitting there going, I'm not comfortable. And fortunately for me, 2 hours later, he declared himself. He had ribals 2 hours later, okay, and recommenced some ceftriaxone, tap inject 30 minutes later, and in fact those initial cultures finally came back with Klebsiella, okay, and highly sensitive to ceftriaxone. So this is one of those cases where you really need to rule out that infection, okay, and it's all on the history. And this is his CT. You can see he's multiple hepatic abscesses, okay, from his systemic infection, okay. And you can see here on the ultrasound he actually had choroidal abscesses from his Klebsiella. Fortunately, we managed to save his eye. drainage of the abscess, intravitreal kephtas, because we knew it was sensitive to it. He ended up in ICU for a few days, so he was not well actually with all of this. Eventually discharged home, and we managed to keep his eye. Alright, so just a few words on Klebsiella, because I know this is an issue in Southeast Asia, and it certainly is an issue increasing in Australia as well. As many of you might know, prior to 1986, it was only known to cause infections, okay? Pneumonia, urinary tract infections. But it was in 1986 in Taiwan that we found our first reported pyogenic liver abscesses in the immunocompetent patient with multiple metastatic spread, okay, through the CNS and through the eye. And I'd just like to highlight here, it could either be fatal or cause significant morbidity. And since that time, we've had over 900 cases reported in the past 10 years. Up to 7% prevalence in cases of pyogenic liver abscesses, and the visual outcome is poor, okay, despite rapid treatment, okay. So final visual outcomes of a case series of 626 cases, okay, high rate of blindness. All right. So the virulence of Klebsiella pneumoniae is thought to be increasing. It's linked to this K1 serotype, which is currently rare in US, Europe and Australia, but it is the most common serotype in Southeast Asia and Taiwan. So this is something that we all need to be aware of, because they often may present with their ophthalmic presentation, like our fellow here that I had, okay, prior to really, the penny dropping with regards to the sepsis. So this is a case where you need to take that history because you might be saving your patient's life, okay. And because of the increasing reports of this condition, the WHO has tagged Klebsiella pneumonia as being an emerging global infectious disease. Okay, so in the acute undifferentiated posterior uveitis, always think infection. Okay, you've got to do a thorough history and examination, both ocular and systemic. Okay, have a low threshold for doing that tap. Okay, particularly in the setting of suspected infection, you've got to look for that focal lesion. Okay, and if you're really not sure, you really don't know, you want to hedge your bets, use oral steroids, don't inject the steroids until you're absolutely sure of what you're dealing with, okay? Otherwise you're going to, once that triamcinolone, once that steroid goes in to the eye, it's damn hard to get it back out again, alright? So don't do it until you're absolutely sure. So take our points, take that history, and examine them, dilate them up, got to have a look. Always think of infection. Avoid a shotgun approach to the investigations. Be targeted, depending on the history and the examination that you've required from the patient. Okay? And Rupesh's going to talk about masquerade, but in atypical cases, you've got to think broadly, is this inflammation or not? Okay, I'd like to stop there and just take any questions. Thanks. Okay, do a subconch local anaesthetic in just the inferior corneas, just down here. Just 2% liquid pain meat. Okay, just pop it in there. Just take your Warfields, snip, snip, done. Informal, and off you go. And pad the eyelets. I put some Corsic ointment in, put a double pad on, and it's done. It heals quicker than a Pallasium.
One more question about uveitis. I think it's very important, I treat individual patients. It's not only to take history blindly, but to have a systemic and thorough history.
Absolutely.
For example, asking the patient if you have any back pain, or go ahead, asking about tinnitus, asking about different. Do you do that?
I do
as
that
a
with all
regular?
my patients. So I actually tell my patients.
Can you highlight this?
Oh, okay, sure. So I usually tell my patients, I'm going to ask you some questions going from top to toe, because sometimes symptoms that you have personally might be related to your ocular presentation. So I literally go from top to toe, okay? So headaches, tinnitus, sore ears, sore nose, okay? So I see scleritis patients as well, okay? Sinusitis, okay? And particularly nosebleeds, okay? Now, just stopping there, headaches for VKH, tinnitus for VKH, sore ears, sore nose, sinus, nosebleeds is for vasculitis associated with scleritis and orbital inflammation. Then I go further down, I talk about lungs, okay? And what I want to ask about is mainly sarcoidosis and again, things like vagus, okay? So asthma. Now, one thing about asthma is that asthma is a diagnosis of the young adult and child. If you've got a 50-year-old diagnosed with asthma in the recent history, so in the past 6 to 12 months, it's unlikely to be asthma. Alright? If it's asthma, it was there since childhood or young adolescence. So that's something that you need to sort of think about, and for me it raises alarm bells that I might be doing with sarcoidosis. Okay? So ask about lungs, chronic cough, shortness of breath. Okay, these are all trigger sort of big questions that I ask. Then I ask about gastrointestinal symptoms. This is for inflammatory bowel disease, also another cause for mainly anterior intermediate uveitis. But I ask about altered bowel habit. What you're really looking for is diarrhea, okay, and bloating, and particularly the big warning bell is blood and mucus in their stools, okay. Now, one of the great tests now is something called calprotectin, okay. If that's positive, it's very, very sensitive and specific for inflammatory bowel disease, so ulcerative colitis and Crohn's disease. Okay, so that's bowels. Okay, then I ask about leg, the musculoskeletal system. I'm asking about inflammatory arthritis. Okay, so back pain, particularly in acute anterior uveitis, and then I talk about joints. So what you're looking for there is inflammatory arthritis. So a swollen joint or sore back first thing in the morning. So inflammatory back pain or inflammatory joints are worse after rest. Okay, and typically in the morning when they wake up, they'll say my back's really sore, my knee's really swollen, really hard to limber up, takes hours for them to limber up. Okay, that's very classic for inflammatory back pain. As opposed to musculoskeletal back pain, worse after activity, okay, and the ache isn't there for more than half an hour at the most. Okay, so inflammatory back pain or inflammatory arthritis takes them a long time to limber up in the morning. Okay, so that's the joints. Then I ask about neurological symptoms. So tingling, numbness, loss of control. That's again for intermediate uveitis for MS. Okay, is one thing, and also vasculitis. And then I talk about systemic symptoms, so generally malaise, fevers, weight loss, night sweats. And again, some of that is due to TB, infections like that fellow with Klebsiella, and also for masquerades, okay, for lymphoma. So I ask all of my uveitis patients or ocular inflammatory disease patients these questions. Yes?
Okay, regarding to the interferon gamma assay, like the quantiferon TB Go, what do you think about use this at the screening and how to interpret it? We have the program to interpret it, especially in the immunocompromised patients. And if the level bother you, if it comes in the immunocompromised patient and it's just low level for the person.
Yeah. Okay, so the interferon assay or the quantiferon gold, what you'll get or what you should get is not just a positive, negative, and you can determine it. You should actually get the control level, then the TB antigen level, okay, and that's what you actually then determine as to whether or not it's positive or negative. Okay, so basically the mitogen is the positive control, and so in an anergic patient. So a patient who's on immunosuppression or a patient with disseminated tuberculosis, you'll find that TB antigen level will be low. Okay, so the response will be low or negative. Okay, and then you know you've got an indeterminate result. Okay, and then you either need to repeat or you need to think about investigating further. Okay, and really look at is this disseminated tuberculosis. But what I say to all of my residents and things like that, trainees, is that these tests are most sensitive at the time prior to starting immunosuppression. So once you've actually got an immunosuppressed patient, you need to rely on other things, unfortunately.
So we all understand the importance of electoral history, but it's only feasible to have like 5 or 7 patients in the morning. We have like 100, so we have the standardized questionnaire.
Yeah, so I can provide one if you need to. I do know basically some of my colleagues, what they do is whilst your patient is waiting in the waiting room, get them to tick off, do you have any of the following symptoms? Okay, tick, 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 tick. Most of the time it's no. Okay, and then you can just go back and just look at the positive ones, but at least you've made that record. And that just helps streamline things just a little bit.
Yeah, that's a good point. So if you can just give us a copy and make copies for everyone.
Oh, it's in my head.
Okay.
There'll be something that I'll have to circulate at a later stage.
Yes, if you can, and then we'll send it on to everyone. But I think that will be a useful aid.
Yeah, the other thing I also sometimes do at a busy clinic is I ask the patient to come back at lunchtime or a bit later on down the road when I've actually finished seeing all the DME and AMD patients and all that sort of thing, and actually take the time to actually, because they understand they've got a bad condition and they're willing to wait.
May I bring you back to the contemporary?
I have a feeling I didn't answer your question.
Okay. So, do you use it at the follow-up? And when you try to start the anti-TB medication, when you start the systemic steroid?
Yeah, so that's I'm going to hold on that question. I am going to do a talk on the treatment. The only reason I'm going to hold on that is because I know Rupesh is going to talk about TB, and so he's got a lot on TB, and so let's hold it for that, and then we can answer that question for you.
Quick question. All you vasculitis patients, do you do PRP?
That's what I was understand that.
There's all sorts of different things of what vasculitis is. Okay, so it's an occlusive vasculitis. So on angiogram, we see all this capillary non-perfusion and the vascularization. I do a combination of systemic immunosuppression plus the PRP to the ischemic areas only. Now, if they actually just have patchy areas of venous sheathing and good capillary perfusion, no neovascularization, no, I don't do a PRP. And that fellow I'm going to present a little bit later, and you'll see why I did the PRP. Okay, but basically in that situation, he actually had widespread capillary closure peripherally. So it was a combination approach. Now that is contentious. Some people just immunosuppress and not laser. But given the degree of capillary non-perfusion, I don't have a lot of faith in some of my patients that they're going to be compliant like him. Yep.
One more. Also, for those of you who want to ask questions in Vietnamese, please feel free, and we'll get it translated for Dr. Lim.
I don't know.
You can learn. Yeah.
Regarding of the mobile hypopia, is there any definitions of the mobile hypopia, and is there any variable?
Yeah, so they call it a mobile hypopia because the inflammation is largely consistent of just white cells and not a lot of the fibrin that you usually see with the acute inflammatory hypopia that you see with B27, okay? So with B27, it's characterised by not just the degree of cells, but also a huge amount of haze and fibrin. And the haze and the fibrin, particularly the fibrin, it gives you a plastinoid sort of aqueous, so nothing moves, okay? Even the cells don't move. In comparison, Behçet's, it's characterised by just cells without usually all that fibrin, okay? And so as a result, the eye is not as red and hot. You see the hypopia and it just moves, okay? Because it hasn't got all the fibrin actually holding it all in place. The other differential is also masquerade, but Rupesh is going to talk to you about that too. Okay, so you sort of take it all, you don't just take one sign, you've got to take it in the context of the patient. So with Behçet, they usually have the ulcers, they've got more an inflammatory arthritis or pathogen, they've got something else going on as well.
May I ask you any false positive for intra-outer like acid tap with some false positive?
Yeah, so false positives and false negatives are always an issue with any investigation. Basically, that's why, that big equation that I put down with Bayes' theorem, okay? You need to be really targeted about your investigation so you make sure that you're not sort of waylaid by false positives and false negatives. Generally, the herpetic PCR for, say, acute retinal necrosis is actually pretty specific and sensitive, which is nice. The toxo, not so, okay? So you get a lot of false negatives with the toxo. Was that what you were asking?
Yeah, but with the false positive, I mean, in case if the anterior uveitis and with the TB positive and PCR.
Yeah. Okay. I generally don't, for anterior uveitis, I generally don't do a TB PCR. TB PCR, like toxo, is actually it's not that reliable either. And so you've really got to sit there going, well, do I really think this is TB related? Okay, and that's something Rupesh is going to talk to you about I have a fairly firm view of what makes TB and what doesn't make TB. And for me, I test for TB in patients who are immunosuppressed. But this is a whole discussion, and I think I'll leave that to Rupesh because I know he's going to talk about TB a lot. All right, I'll be back up here again soon.
Okay.
Thank you very much, Lyndell. Our next speaker is Dr.